going to go ahead and continue with our session for E&M for telehealth guidelines today. As I mentioned, the encore, because I just started that recording, we will make this session available on our website for the next 60 to 90 days without needing to access a YouTube player. We do recognize not everyone is able to see or access YouTube at work based on security restrictions that we all have to deal with on a daily basis. So that's going to be available there. It will also be available on our YouTube channel as long as the information is accurate and relevant. That's just going to allow you to be able to look at that again if you have any questions, there's something that you want to see, want to reference again, or if you know of anybody who would benefit from this material that perhaps was unable to attend today. Questions, we are taking questions today. They are going to be taken through the chat. Mary is monitoring those, and I will be checking in with her throughout the session for those questions. I encourage questions. Please throw those out there as you have them. I don't want anyone to forget any questions that they may have. If for some reason, though, we have more questions than time allows for today, not to worry, I will be putting together a follow-up document that will include all questions and answers from this session, and that will be sent out to all attendees so that you will have that information. And then finally, before we get started, I would appreciate you taking some time to provide us some feedback. Towards the end of this session, you will be provided with a couple of different ways to take our survey. This is your opportunity to tell us in CMS how we did. What did you like about the session? What didn't you like? What could we do better? We use that information to adjust our education and make sure that it's relevant and meaningful and that we're helping you navigate the Medicare program. So the other thing you can use this for is to provide us with information on topics that you would like to see in the future so that we can develop education to help you. This is our disclaimer. The information in the session today is accurate as of today. If you've worked with Medicare for any period of time, you are aware that Medicare changes often. So this is a reminder to make sure that you continue to monitor official CMS communications, which includes the CMS and the WPS website, to stay up to date and current on CMS rules and regulations. I will be answering questions based on those regulations along with the information presented today. Also, CMS does prohibit photographing, screenshotting, or recording the education for profit-making purposes. And as I stated, we are recording the session today, so you will have that recording available to you. One more disclaimer before we get to our agenda. So this is the American Medical Association's copyright notice for CPT codes, their description and any other data. So we will be showing you some CPT codes today. So your continued participation in this webinar is inferring that you agree to the terms of this copyright notice. That brings us to our agenda for today. So as I stated earlier, today we're going to be talking about telehealth, specifically with regards to medical services and not non-behavioral health services. Again, mental health, behavioral health service, telehealth guidelines were covered in a webinar previously, and that link has been placed in the chat for you if you'd like to look at telehealth specific to behavioral health. As I mentioned earlier, that is because the guidelines are going to be different for the two types of services, and we wanted to make sure that there was a clear line between. So today we are going to talk about services that can be provided telehealth. This is going to include looking at the list of telehealth services that CMS maintains. We are going to talk some about the Originating site. We will talk about audio communication requirements, and we are going to talk about some provider enrollment scenarios for telehealth. There have been questions about these since the start of the pandemic, and we're going to talk about through those some of those scenarios, because with telehealth, providers are in remote locations. How does that impact enrollment? And it does. Also, as I'm sure many of you are aware, that there were flexibilities that were put in place at the start of COVID-19. Those flexibilities were scheduled to expire on December 31st of 2024. However, and this is the piece that I'm sure everyone is aware of, Congress did take action and expand some of these flexibilities till the end of March 2025. I am going to go over telehealth guidelines as they stand without the flexibilities, but I am also going to call out throughout the presentation, and you'll notice that this on my slides, I have a call out on those, but I am going to call out where the flexibilities that were allowed to lapse have been extended until the end of March. I've also included a list of acronyms today. I will be using these. I'm not going to read through them for you, but they are here for you for your convenience should you need them throughout the session today and after. So here I'd like to start with Telehealth Overview. This is going to be that baseline for those of you that maybe are not as familiar with telehealth. So essentially telehealth is a substitute for an inpatient visit, and it's going to allow for certain healthcare services to be delivered remotely, typically using an interactive audio video telecommunication system. So there are a lot of benefits to this. Not only is it more convenient, but it can also allow for greater access to care and improve patient outcomes. Telehealth can eliminate barriers to receiving care that may be in place for certain beneficiaries. Depending on location, it could be access to getting to the physical location. There's a lot of reasons why there's a barrier. And this again is just allowing for that greater reach so that it's ensuring that those that need care are able to receive care if it's approved through telehealth. And again, it does need to be appropriate to be something that is deliverable through telehealth. As I said, it has to be appropriate. So not all services are a good fit for delivery via telehealth. And as I've mentioned a couple of times, CMS does maintain a list of the services approved for telehealth. We are going to talk about that through later on in the session today. And that list is going to be critical for you knowing whether or not the service that you're wanting to bill Medicare for is something that can be performed via telehealth. As I said, we're also going to touch on flexibilities. Some flexibilities that were in place during COVID were made permanent, and this is primarily this is really directed at those behavioral health flexibilities. For instance, audio only. Those are services that have been made permanent. I'm not going to go into detail. Again, there was a session on that, and I would encourage you to take a look at that if you have questions specific to telehealth for behavioral health. But for non-behavioral health, some flexibilities have been extended until March of 2025. They were scheduled to expire again at the end of 2024, but they have been extended for a few more months. And again, we'll talk about those. I do want to start though with eligibility requirements for a telehealth visit. First, to receive telehealth, the services have to be provided to a Medicare eligible beneficiary. And as with all services covered by Medicare, telehealth services must be a medically necessary service as outlined by the Social Security Act. So you'll still have to have your documentation support the medical necessity of that service, as with any other medical service. It also has to be a service that is otherwise covered by Medicare, and this includes meeting statutory coverage requirements. So it's not an statutorily excluded service. And in addition, as I mentioned, and we're going to go there, but it has to be a CMS approved telehealth service. Not all services are approved to be delivered via telehealth. And like I said, we're going to go through that in a minute. And typically, telehealth services must be provided to the beneficiary in a qualifying geographic location. Typically, these are rural areas. However, as I mentioned, there have been extensions to those flexibilities put in place through the American Relief Act of 2025. And I have included a link to that in your presentation material today if you'd like to look at the verbiage in that. But to summarize the extensions, flexibilities have been extended for geographic location. So that is going to mean that the typical need for it to be in a more rural location is being, the flexibility is being allowed for that. Also, Flexibilities are extended for the expanded practitioner types that were in place during the pandemic. Those are not going back to pre-pandemic restrictions. Also, telehealth is continuing to be allowed temporarily for FQHCs and RHC telehealth services. And I saw the question in the chat. We will talk a little bit about the billing. It's pretty relatively simple, but we are going to touch on that so that you have that. And then we're going to talk about audio only services. Again, these are extensions, and you're going to see this at the bottom. You'll see that note, flexibility is extended. As we go throughout the session today, when we're talking about a telehealth requirement where a flexibility has been extended, I am calling it out with that note so that it's easily identifiable for you where there's a flexibility at least through the end of March. Now, I do want to call this out. We have gotten some questions, quite a few questions prior. They were pre-submitted questions for this session. A lot of questions about what happens on April 1st. So I just want to address that now. So at this point, these flexibilities, as I continue to state, are extended until the end of March 31st. Barring any CMS or congressional action, these flexibilities would be left to expire, and the normal telehealth requirements as outlined in our IOM are back in place. That would basically remove or put back in place the geographic location restrictions, the practitioner type, and restrictions with audio only services. At this time, we do not have any communication that anything different is going to happen in April. So where we are today is that these flexibilities are extended until the end of March. So back into the telehealth requirements, we are going to talk about the technology requirements. So for telehealth, it does require a two-way interactive audio video communication. So audio and video where you can both see and talk to and interact with that patient. Two-way interactive audio, that is something that has been put in place permanently for behavioral health. Right now, this is a flexibility that has been extended to non-behavioral health. And again, that flexibility is through March 31st. The technology does need to be HIPAA compliant, which means that it does need to protect the patient's privacy. And just like with any other service, the patient must consent to the service unless the service requires a specific consent. So you just need to make sure that they're aware that this is occurring this way. Patient must allow you to submit the claim to receive payment, and you don't need to get a specific consent each time. Just make sure that that consent is HIPAA compliant. So next I want to get to the list of telehealth services. So CMS determines the services that are payable as telehealth, and they maintain the list on the CMS website. I will be going out there in just a minute, but I have also provided a link for you in the materials today so that you have easy navigation. CMS does not maintain an archive list, so when we go out there, you're only going to see that list for today. And the list will include a description of the services. It'll include a category of a service, whether it is permanent or provisional, and we'll talk about that. And these are the services that can be billed for telehealth. So let me access that. So to access it, I do have it pulled up, but to access it, I typically search for it on the CMS website. So I am going to just type out telehealth and search for that. And there is a list of telehealth services that comes up. I'm going to access that, and then you'll see the list of telehealth services for the calendar year. Now we'll talk about this in a second, but I just want to talk about this page a little bit. The landing page that you're coming to is going to be the list of services for the current calendar year. There's also going to be some links on the left side if you would like to request additions. If you go in there, if you're not seeing a code, there are instructions for how to request additions to this telehealth list. They do need to be reviewed and approved by CMS. We're not going to spend time talking about how to get a code added today, but I did want to make you aware of that. As things evolve, you may find codes that you'd like CMS to consider, and this is where you can go to make those requests. So back to the list of telehealth services. I'm going to go ahead and open that up. This is a zip file, so you will need to be able to unzip a file in order to access this list. And it's pulling up. One moment. There we go. And this is the finalized list of Medicare telehealth services. In the pre-submitted questions, I did see some questions about various types of services. I'm not going to go through the entire list, but my advice, if you're wondering if a service is something that is payable when delivered through telehealth, you want to consult this list. So this list, column B, is going to be that HCPCS or that CPT code. Column C is going to include a short descriptor of the service. It will be, again, a shorter descriptor. It's not going to be a full description. And then it is going to show the finalized action, whether it was maintained or changed from last year's list. That's going to be column D. And then you're going to see column E, which is telling you whether or not the code is permanently on the list or if it's provisional, which means it will likely need to have some refinement or some changes to policy that reflect that service being delivered through telehealth. One thing, if you've used this list in the past, you're going to notice there's no longer a column for whether or not audio only is eligible. And we're going to talk about that with audio only codes. There were some codes that were removed. CPT created some codes. We will talk about those, but ultimately you do need to come out here to check this list to see if a service is something that can occur through telehealth. Some of the codes that you are going to see that have been added on a permanent basis, they have added some caregiver training, and there's a few other codes that are out there. So if you were looking at last year's list and the code was not eligible for telehealth, I would encourage you to take a look at this because there have been some changes made. So I mentioned audio only codes, and this was probably uh, the item that we received the most questions in the pre-submitted questions. So I am going to handle those here. So with audio only services, one of the questions that we've seen is, what do we do? How do we bill for these services? Because the audio only codes, the 99441 through 443, have been removed. Those have been removed. You will not be billing using those codes. Now, you'll be able to bill the audio only codes now if the provider does have that interactive audio video technological telecommunications ability, but perhaps the patient can't or won't, and then they need it to be an audio only code. Through March, audio only services are still something that can be billed. The way they will be billed is using the appropriate evaluation and management codes for the service that's being provided. And what you will do to let us know that it's audio only is going to be through the use of modifiers. So a 93 is going to be an audio code for everybody but RHCs and FQHCs. RHCs and FQHCs are going to use the FQ modifier to let us know that the services were provided audio only. Now those modifiers are just for audio only. They're not telling us that this was telehealth. We will talk about place of service for inpatient home and not inpatient home, basically everywhere else later on in the presentation. But this is how you will bill through March. After March, unless action is taken by CMS or Congress, if these flexibilities are allowed to expire, audio only is no longer going to be a possibility now, or eligible for payment. Now, the other question that we're getting are the new CPT codes that are audio only codes, specifically 98,000 through 98,015. Those codes are, if you look in the relative value file in the physician fee schedule, those codes are a status I. They are not codes that are recognized by Medicare. Those codes are not being used to bill Medicare because the intent is not that Medicare is at this time. These are flexibilities that have been extended, and those audio code only codes are not going to be billable. So moving on to who's eligible to provide these telehealth services. So physicians, MDs, DOs, non-physician practitioners, so your physician assistants, nurse practitioners, physical therapists, because this is part of that expanded practice. Again, the flexibilities have been extended. Occupational therapists, speech and language pathologists, audiologists, as I mentioned earlier, the RHCs and the FQHCs. This is a flexibility that's been expanded. So again, through March 31st, the providers must be licensed to provide the services, and they need to be providing services that are within their scope of practice for their state and where they're licensed. We know with telehealth, we do have providers that may be in a state that is different from the patient. The providers do need to make sure that they're meeting all licensure requirements for providing that service in that state. Next, typical geographic locations. So again, this is another flexibility that's been extended until March, but typically we're looking for services to be rendered in a healthcare provider shortage area or counties that are not classified as a metropolitan statistical area. So rural locations. The patient is going to be located in that geographical area. The provider is going to be located in those areas. They're providing services to those more rural areas. The patient can be located anywhere, but this is again, something that has a flexibility through March 31st, and those geographic location restrictions are not in place until April 1st. Next, I want to talk about the originating site, and you're going to hear about this often when we're talking about telehealth. So this is the location where the patient is located at the time the service is being furnished. Going back to before the PHE, patients needed to have been in those rural areas outside of those metropolitan statistical areas. And again, those flexibilities are removing that at this time. But when we're talking about a patient's home, it really means where the patient is, and it doesn't necessarily mean it could be anywhere. Basically, the patient can be anywhere. We do have place of service codes that we'll talk about, one that is specific to their home, but one is that they're anywhere else. So we'll talk about that. Medicare does not require the patient presentation by that medical professional. So again, this is happening through interactive audio video or until the end of March, audio only communication. You are going to see that an originating site procedure code, that's the Q3014, that is going to be billed only when the patient is receiving telehealth services in a facility. So if it's the office, if it's the facility, this can be billed. The Medicare allowance for that code for 2025 is 3101, but this is not something that's going to be billed when the Medicare beneficiary is receiving the services in their home. So again, it can be billed in a physician's office, RHC, FQHC. It's someplace when the beneficiary is someplace other than their home. So some examples of those originating sites are going to be hospitals, critical access hospitals. I've mentioned the rural health clinics and the federally qualified health centers, also skilled nursing facilities and community mental health facilities. There's, again, not a geographic restriction on the originating site. That restriction is going to be for that beneficiary, and that patient does not have to be in an originating site if they're receiving those services from home. Now, the opposite side of that is going to be the distant site. The distant site is where the physician or practitioner or other qualified healthcare professional, because again, we have uh, those expanded specialties or provider types that are able to provide these, but it could be an office and it could be the practitioner's home. And that's going to be where we're going to get into some of the enrollment examples, because that does sometimes pose questions. And I don't want to say so much complications, but we do get a lot of questions about how the providers should be set up. So ultimately, the distance site is going to be the address that's going to go into box 32 or the electronic equivalent on the 1500 or the 837P. It's going to need to be on the enrollment record unless it's going to be the provider's home at this time. There's an extension there and we're going to talk about it. CMS is aware of the situation where the providers are reluctant to show their home address as a practice location, and this is going to be part of the examples that we go through. There is an extension where the providers do not have to provide their home address until the end of 2025. However, there are going to be instances where that's the only address and it does need to be reported. So one thing that I do want to make everyone aware of, the address is needed to determine the MAC that's going to be billed, especially when there isn't a practice location available. However, there is a way to suppress those addresses, and that's the reluctance. Provider locations are listed on the compare list that's out there, that directory that's out there, but home addresses can be suppressed using the CMS 855I or CMS 855B enrollment forms when the location is either added to the enrollment or as a change, to make sure that that address information comes off of the list. CMS does want to protect the privacy of those home addresses, and so there is a mechanism in place for suppressing that from being public. So let's take a look at some of our enrollment examples. Again, this is something that we get more so from the provider enrollment side about what needs to be reported and how does my provider enroll in order to provide telehealth services. So we're going to talk about a couple of examples that we see often. So in example one, this is an example of a provider that has a private practice. They're not reassigning to a group, and they're providing telehealth services. So the provider has a practice, in this example, has a practice in Kansas, and they're providing telehealth from their home in Kansas. So this provider, they're not reassigning benefits. They're going to complete the CMS 855I. In this scenario, they don't have a physical office address. They are purely using their home address. This is an instance where that home address simply has to be reported, because we cannot bill an enrollment record for reimbursement without some type of an address. So with that home address being added, the provider is going to indicate that either it's a business office that's administrative or telehealth only, they're not seeing patients there, or that it's a home office and administrative for telehealth only. That's going to let us know, put the address on the enrollment record. We have to have that, but it's not going to be published for everyone to be able to see. Again, protecting that provider's privacy. However, we simply cannot set up a provider transaction access number, or PTAN, for billing without a practice location. And the claims are going to be paid based on that home location. And that's another reason for that practice location. A lot of information goes into that for reimbursement. Our next example is a provider who is reassigning to a group in the same state in which they're providing telehealth services, and the group has a physical location or a brick and mortar office. So the group is located in Kansas. The provider is not necessarily providing services at that group's location. They are providing telehealth services from their home, but they're in the same state as the brick and mortar location for the group. In this situation, the group would already be enrolled with that location, or they would need to submit an 855B application with that brick and mortar address. The provider that is providing those telehealth services and reassigning to that group is going to need to submit a CMS 855I, indicating that they're reassigning to the group with that brick and mortar in Kansas. What happens here when claims are submitted, claims will be paid based off of the group's information. The provider's not going to give us an address on that 855I because they're reassigning benefits. And when they're reassigning benefits, the practice locations are coming from that enrolled group. The next example is going to be an example of a provider who is reassigning to a group that is located out of state, but the group does have a physical location. So in this instance, the provider is providing telehealth from their home in Florida. The group is located in Kansas. So this is, again, we have two jurisdictions. We have two MACs involved in this case. Claims are going to be submitted to Kansas because that group is located in Kansas and has an address in Kansas. That group is going to submit an 855B or already be enrolled with their physical location in Kansas. And similar to our last example, the provider is going to submit that 855I and reassign to that group with that Kansas address. The claims are going to be paid based off of that Kansas enrollment because that is where they're enrolled. At this time, again, we're not asking that provider to provide that home address because they're working for a group that has a brick and mortar address in the state. The biggest thing here, and it comes back to what I was mentioning earlier about the scope of practice for the license, they also need to make sure that they can provide services in Kansas with the license that they have. Every state's set up a little different. A lot of them do have reciprocal arrangements, but that is something that does need to be looked at before enrolling this way. And the last example that I am showing is a provider that's reassigning to a group with no physical location. So they're only doing telehealth services. In the first example, the provider may have had a physical location in the state they're practicing. Here, they do not. So in this case, you're going to have a provider that is providing services from their home in Kansas, and they are reassigning to a group that does not have a physical location. The group itself is just for telehealth. So in this instance, the provider is providing services from their home. They're going to need the group to enroll with a CMS 855B in Kansas, but they're going to have to list that home address because there needs to be an address, there needs to be an enrollment to be paid. That address is what's setting up fee locality for that reimbursement. So they will, in this instance, because it's the home location, they are going to indicate that it's a business office for administrative and telehealth only. And then the provider is going to reassign. And as I indicated, based on the fee schedule, those claims are going to be paid based off the provider's home address. So with that, now I'm going back a little bit to billing telehealth. So we talked about the modifiers earlier with regards to audio only, and I also want to spend some time talking about the place of service. So to bill telehealth, you're going to need to tell us where that patient is. So place of service 2 is going to be used when the services are not provided or are provided somewhere other than the patient's home. Place of service 10 is if the patient is in their home. One thing I do want to state, though, if you have a patient that is domiciled in a nursing facility, that is still technically place of service 2. That is everywhere else. 10 means that the patient is in their home. One of the questions that we received was about using modifier 95. That is a code that is no longer needed because the place of service is going to tell you where the patient is. So again, place of service 10 means the patient is in their home receiving the service, and place of service 2 means that the service is being provided somewhere else. Now for the modifiers, again, coming back to those audio only because we received quite a few questions on that. CMS is not recognizing CPT's new audio only codes, and they have deleted the previous audio only codes. You will use the appropriate E&M modifier with A93 to identify it's a synchronous audio only service. And then for your RHCs and FQHCs, you'll use NFQ. With all of that, though, I do need to stress again that those flexibilities have been extended until March 31st, specific to geographic location, practitioner type, the FQHCs and RHCs, and audio-only services. Again, no information as to what to expect in April other than flexibilities will no longer be in place as of April 1st unless there is some type of CMS or congressional action. So at that point, things would go back to the restrictions on geographic location for HIPSA and MSA area. Practitioner type restrictions would go back into place, and audio only services would no longer be something that could be billed. Before I check in with Mary for questions, and I do see that we do have some coming, I did want to leave you with some resources. The first one is a medical learning network product that is for telehealth services. One thing I do want to call out is CMS did announce the March 31st extensions in an MLN Connects news article on January 16th. However, you're not going to see those extensions. I checked right before this session. They are not in the MLN for telehealth service just yet. I have also included a link to the Medicare Processing Manual, Chapter 12. This is specific to telehealth, and it's Section 190.3. These are the telehealth guidelines without the flexibilities that we talked about today. And again, the flexibilities run through March. I've also given you a couple of links to some other resources, our telehealth.gov and our physician compare. And that physician compare is where we are able to suppress the provider's home address if it's reported to us. With that, I am going to check in with Mary. Mary, what questions do we have in the chat?
Okay, Leanne, we are getting some questions. Could you, there's quite a few of them that are asking about place of service. And I know you and I had a conversation about this just recently. They're asking if an assisted living facility, if a skilled nursing facility, and domiciliary locations are considered the patient's home, or whether they would be billed with place of service too.
Yep, those are going to be billed with place of service. The patient is there, but they are not considered the patient's home. They are a medical facility. So those would be billed with place of service too.
And I need to make a correction. I sent out a message to everyone saying that the location is place of service 10. It's 2. I typed the wrong thing. I have a lot of questions coming in, so I am trying to get through them the best I can. So I will make that correction. There's also some questions, Leanne, about state scope of practice. You know, if the physician or practitioner is in one state, the beneficiary is in another. Can you talk a little bit about that, please?
So the provider is going to need to enroll in the state where they're is going to need to enroll. And depending how they're set up, we talked about some of those scenarios. So for instance, you have a provider that's in, I'll go with the one that was in Florida, and they're enrolling in Kansas. So the services are going to be billed in Kansas. So we're going to need to make sure that they're meeting the scope of practice for where they are billing those services. Now, oftentimes with physicians, there are reciprocal arrangements, but that is something that does need to be looked at when they are crossing state lines. When that provider enrolls and submits their application to enroll in that state, our provider enrollment area is verifying that licensure information, and they will develop if it is something that is not meeting those requirements. Um, they just need to ensure that with the license that they hold, they are able to provide those services, or they are able to get the licensure that they need in order to provide those services in the jurisdictional state.
I'm getting some questions about the use of modifier 95. And I know that this isn't generally used, but there is one little exception. I think that it's best if we send an email out following the webinar about that particular exception, because I know there's kind of if, ands, or buts. So regarding the use of 95, typically it's not used, but there is an exception, and we'll send more information out on that so that you can find that. Leanne, I think I've gotten most of the questions. If not, please add your question to the chat. I'm scrolling because I know that I answered a lot of these questions. You know, getting questions about the 95, place of service code, 10 versus 2. Looking for more here. Behavioral health providers, can they bill E&M audio or only psychotherapy? We have asked CMS to provide clarification on whether they can bill E&M audio, but it's our understanding for mental health or behavioral health, telehealth services, if the services that are being rendered are being provided for treatment of a mental health disorder or substance use disorder with co-occurring mental health treatment, then the service may be billed as an audio-only service, and that is permanent, folks. That is one of those little differences between mental health or behavioral health, telehealth services. That's a permanent change, that services can be billed audio only, but you need to make certain that you're documenting in the medical record a couple of things. First of all, you're going to need to let Medicare know that you have the capability to use audio video, and that the beneficiary doesn't have the capability or simply does not wish to use the visual component of the audio video communication. So make certain that you're putting that into your documentation. I'm going to scroll to the bottom of the list to see if any questions have come in. Can you go back to slide 22, please? The provider example 3. I'm getting some responses or some notifications that the slide that we're showing is different from the one in the slide deck. Could it be possible, maybe, Leanne, that we updated one of these provider examples?
I did. I should have called that out. My apologies, folks. I can send out this slide so you have that updated slide. That was simply a typo. I think it had Nebraska in there, and it should have had Kansas. I can get that sent out.
Okay. Question here is when it's appropriate to use Q3014, or who it is that would report the Q code. What's that used for?
So that Q code is going to be used for the originating site. That is going to be the telehealth facility fee, and it can be billed, but only when the patient is receiving telehealth services in a facility. Now, a facility can be that office, it can be the hospital, it can be the FQHC, the RHC. It's not used when the patient is receiving the service in their home.
Okay, I am going back to some questions that came in a little earlier. Can we use evaluation and management audio only if the patient calls in on the weekend?
Mary, I want to make sure I got all of that. Can you give me that one again?
Sure. Can we use E&M via audio only if the patient calls in on the weekend?
You need, if it is a medically necessary service and it is an E&M that you can bill and it's on that CMS telehealth list. So it has to be a service that's on that telehealth list. There aren't restrictions for when the service occurs. So it's a matter of that being an eligible service and using those appropriate modifiers and place of service.
I did get some questions about CMS's new definition of direct supervision, and I did place that information out into the chat. Now, if you didn't see that when I posted it, it does say that under the new definition of direct supervision, CMS clarified that services that can be provided incident to may be provided via telehealth incident to a distant site physician service and under the direct supervision of the billing practitioner via virtual presence. So something to keep in mind. Again, folks, remember that if you are treating or if the treatment is for a mental health disorder or substance use disorder with co-occurring mental health treatment, your rules are going to be a little bit different. All right, I'm back to scrolling here, Leanne.
Thank you, Mary. Mary, I just saw one that came in at the end. It is regarding modifier 95 that I know I can clear up quickly. It is asking if even though modifier 95 is not necessary for audiovisual service, will a claim be rejected if modifier 95 is included? And the answer is it won't be rejected. It's just not something that's needed.
Oh, perfect. All right, and I did mention to you that I'm going to do some digging following because I do remember seeing something somewhere that did mention that there was a certain circumstance that the 95 would be used. Mm-hmm. I think it had something to do with if the physician was in the hospital rendering the service and the patient was at home. But I am going to dig that up and get it out to you to make certain that I'm getting you the information.
Thank you, Mary.
Let's see, there's a new question that says, I tuned in late. Will there be an encore presentation that I can listen to? Do you want to talk about that again, Leanne?
Absolutely. There will be an encore presentation. It will be posted as soon as possible after this session, barring any technical difficulties. That usually happens within a week to 10 days. Sometimes it's sooner than that. That will be available on our training center, and it will be available on our encore presentations page, and it will be available there without needing to access YouTube. It'll be available through our player, our embedded player, for 60 to 90 days. After that, it will be available on our YouTube channel as long as the information is correct and relevant.
All right, another question. This one's mental health. Mental health provider is at home while the patient was in the office. Do we add the 95 modifier with place of service too? And the answer to that is no. We are no longer using the 95 modifier for that situation when your provider's at home and the patient is in the office. All right. Another question here, Leanne, is can dermatologists bill a telehealth service?
So that's going to be where you're going to want to check that CMS list. At dermatologist, I am presuming is going to, what you're talking about is going to be a dermatologist who is obviously that MD or DO, that is a physician. They can bill telehealth service. So then it comes down to looking at that CMS telehealth list to see if the service that's being billed is eligible via telehealth.
All right. I know we're getting some questions on RHCs and FQHCs. They've typically billed FQ modifier for mental health audio only visit. It states FQ should only be used for an RHC department will receive denials. Because this is so specific to mental health, what I would recommend you do, Diana, is take a look at the, we have an encore presentation for telehealth services that is specific to mental health. While it is specific to Part B, I do remember that I included some information in the slide deck about our HCs and the FQHCs. So take a look at that. Leanne, if you have time here, we have a couple minutes left. Some of the questions that I'm getting are about how people can find our YouTube channel. And I think if you take them out to our training center and show them that page, they can find how they can easily get to those encore presentations or those YouTube videos. So let's take a look at that and show people where they can get help.
Yep. So I am going out to our website, and this is our WPS Government Services website. Once you are on this website, if you go out to our training center, and it's always going to be that bar across the top. In our training center, there's the live events page where you can get the materials for today's session, but there's also our encore presentations where you can watch presentations. This is where you can see those encores for 60 to 90 days. One thing I do want to call out, and I'm just going to open one up, it's going to look like it's not working and you'll just get this white box. It is. It's loading. It just takes a minute because we're using an embedded player. It just takes a minute. There it comes. It will load, and you will have access to the material and a chance to leave feedback on those videos as well. It will be here again for the 60 to 90 days. If you are needing something that is older than that, I'm just going to go back. We do also have our YouTube channel linked to our page under our YouTube videos page. And if you go into see playlists, you will have access to our YouTube channel. There's a link there. And then you will also have access to our various playlists, including, it'll just take you out to the YouTube. It'll include the encores. It'll also have playlists that are specific by topic. So there's our encore presentation. So you will have access to that there. A lot of good information, a lot of encores, but also a lot of short little snippet videos that may be helpful to you.
Right, exactly. I do want to let everyone know that I did place in the chat the link to where you can directly link and open our encore that's titled Part B Mental Health Telehealth. So you can get that information if you'd like. I think that we're coming close to time here, Leanne. Based on some of these questions that I'm getting, number one is they're asking, do you mail out the Q&A? And let's move to the follow-up questions slide and discuss how people can send in follow-up questions. So number one, do you email out the Q&As? And number two, what if they have additional questions?
Yep, so follow-up questions. The Q&As from today, the questions and answers we didn't get to from today, will be sent out in a follow-up document to the attendees, and that will be sent out via email to all attendees. Follow-up questions, I am taking those for the next 7 days. And to submit that, you'll go ahead and send your question to that same WPS-GHA education mailbox we were using for technical issues. But this time in the subject line, you're going to want to put the title of today's session, which is E&M for telehealth. That's going to alert the individuals monitoring that mailbox that, hey, this question needs to get to Leanne and Mary to get a response to you. I do want to be clear, though, any claim-specific questions about a claim in process, those do need to still go to customer service because they'll have access to those systems and can better advise you on what next steps to take. But questions about the topic of today, certainly for the next 7 days, send those our way and we will get responses out to you. With that, and for the sake of time, I am going to go ahead and wrap up here just a little bit. I'm going to go back to certificate for achievement for today. So if you are attending for continuing education credits, you are, in a few minutes, all of you are going to get an email thanking you for attending. This is going to be that certificate of achievement. So don't delete that without looking at it. In the lower right-hand corner, you'll see it in a red box there. You're going to see the date and the contact hours for this session. This email can be submitted to your accrediting body or credentialing body for credit towards those continuing education credits. There are a couple of things that may have occurred though if you didn't get it. One, check your junk or your spam folder. Sometimes because this email is coming from our webinar software, it doesn't get past different security protocols that everybody has in place. So check that. The other thing is if you attended by audio only, our system doesn't have a way to confirm your attendance and it wouldn't generate this email. However, you're not going to be out of luck. If either of those two situations happened, email us again to that WPSGHA mailbox. Say, hey, I need my certificate. Also include the phone number that you attended from if you did phone only. Once I confirm your attendance in either situation, I'll be able to manually send you a certificate so you still get those continuing education credit hours. After you leave the session, as I said at the beginning, we really do want to hear from you. We want your feedback. What did we do well? What could we do better? What topics would you like to see offered in the future? So you'll have a couple of opportunities to provide us feedback through our survey. One of the ways is going to be through the chat link that Mary is going to place into the chat. You can click on that. That'll take you directly out to that survey. Also, when you leave today's session, you are going to get a pop-up box. You'll see that in the lower right-hand corner of this slide. That pop-up, it's not spam, it's not malicious, it's not taking you anywhere you do not want to go. It's simply letting you know you're being redirected from our webinar software and going into our CMS Qualtrics survey software. So again, really looking forward to those comments. We do use that to improve our education and make sure that we're giving you what you need. With that, I know we went a little over. I do want to thank all of you for hanging out with us today. This is the end of the presentation. On behalf of myself, Mary, Ashley, and everyone on the WPS Provider Outreach and Education team, I'd like to thank you very much for taking time out of your day to attend today. We do know that everybody is super busy and carving out this time can be a challenge. So again, I thank you very much for attending. I thank you in advance for your survey comments and hope to see you again at a session in the future. Have a great day. Continue to do well. You may now disconnect.